Hello, everybody, and welcome to this quick 5 to 10 minute revision of the various topics, around 953 topics for the NEET PG, FMGE, USMLE, and also MBBS Prof exam preparation. This is Dr. Murli Bharadwaj, your everyday classmate in the preparation. Now, in the myocardial infarction, what are the findings which are against the diagnosis of myocardial infarction? The wrong age. Typically, any patient who is under the age of 40, very unlikely to be an MI without a known heart disease. But there is also a caveat that you need to remember. Strong family history, if it is there even under 40 also, you can suspect MI. But without a strong family history, without multiple risk factors for the coronary artery disease, it is unlikely to suspect in a patient who is below 40. Now, risk factors, you always need to take the history of the risk factors. Suppose if he is a regular marathon runner, even if he is 60-year-old, if he has got a high level of HDL, no cardiac risk factors other than the age, it is also unlikely to have the heart attack. Now, there are certain important clues about the physical characteristics of the pain in case of myocardial infarction. If the pain is reproducible by palpation, it is not from the heart, it is from the chest wall, is what you need to remember. And always, the pain associated with the MI usually is not sharp, usually is not well localized. Somewhere diffusely it is starting inside me, doctor. That's what the patient will tell you. If he is able to well localize it, if it is very well sharp, then it is unlikely to be the pain of the MI. And the pain is not related to certain foods. It is not related to eating, a very important clue. Now, what is an important thing that you look for on the EKG whenever the patient is having MI? Flattened T waves, flipped T waves. On the online MBBS.com video library, in the medicine, we have discussed about 8 hours of extensive revision of ECG. Please take an opportunity to do a revision on the online MBBS.com video library. Similarly, ST segment elevation, very important. If you want to do thrombolysis, you need to look for the ST segment elevation. Good to see Vivek, Pramod Gurjar and many more who are all online. Please be part of our Telegram group, doctor, so that we will be in a position to add a lot of questions throughout the day and engage you almost every day. We have about 240 MCQs which are being discussed on our Telegram group of online MBBS. A lot of students, very active participants, that keeps you up and ready and brimming with preparation. So that's the reason, please be part of our, you're most welcome to be part of our Telegram group. Here I am pasting you the Telegram group address. This is the Telegram group link. See, the short link is there, no? So please be part of this link. Yes, this is a tiny URL link. Do not make it very long. Just if you click, it will take you to our Telegram group. Also share it with all your friends. We want to make it one of the largest group in the world with almost 1 million medical students, doctors, consultants, teachers. And we have not only for the NEET PG, FMGE, MBBS Prof exam preparation, we also are posting a lot of clinical cases, a lot of discussions in order to stimulate that intellectual curiosity among all of you. So please be part of our Telegram group and share it with everybody. So now, Doc, Q waves in the segmental distribution. Typically, lead 2, 3 and AVF is inferior infarct. And you all know very well that lead 1 is a left-sided lead. Similarly, AVL is a left-sided lead. V5, V6 is a left-sided lead. So that is pointing towards the anterolateral wall infarction. So you need to look for it. And ST segment depression means ischemia, elevation means infarction, and injury is what you need to remember, right? Is the Telegram link not opening? Let me check. It is opening, doctor. I'm able to see it over here. I'm able to see that it is opening. Just click on that link, or you put that link into the, it is opening. Or you just put that link into the browser and then click. Then automatically you will be landing in the Telegram. You should also have Telegram downloaded, right? Now, what is the classic pattern of MI chest pain? A very important question. It is a crushing or a pressure sensation. It is poorly localized substernal pain that is radiating to shoulder, arm and the jaw is what you need to remember. And it is not reproducible on palpation, and it often does not resolve with nitroglycerin. If the pain resolves with nitroglycerin, it is unlikely to be MI, it is still angina. If you can relieve it with nitroglycerin, please remember, relief with nitroglycerin is equal to angina. Not relieving with nitroglycerin is equal to myocardial infarction. And the pain usually lasts at least half an hour. A very, very important clue. So now you can see in this, what you're able to see is lead 1, AVL and V2 to V6. See, this is ST segment elevation. This is how ST segment elevation looks like. This is how ST segment elevation looks like. Even V2 ST segment elevated, V3 ST segment elevated. So you are able to see lead 1, AVL, V2 to V6. That means it is an example of anterolateral acute myocardial infarction is what you need to remember. Now, what are the tests that you use to diagnose the MI, doc? Troponin levels, usually drawn every 8 hours, 3 times. A lot of times patients come, ECG will be positive with ST segment elevation in only about 50% of cases who are having the MI. So that is the reason you need to rule out the MI in a patient clinically who looks like MI and who is not having ECG findings. There you need to do at least 3 times every 8 hours before you rule out. The troponin will be elevated for more than 24 hours. Radiograph may show cardiomegaly, pulmonary congestion, very important. Echocardiography will show ventricular wall motion abnormalities. Some of you are going to be the top guys. So, preparing for your MRCP and DM cardiology exam, and I'm sure a good number of you are going to be cardiologists in the short future. So you should be very sure how to do the 2D echo and pinpoint that the pain is due to MI and there are ventricular wall motion abnormalities. So what are the classical physical exam findings in patients with MI? Diaphoretic, anxious, tachycardic, tachypneic, and pale. They may have nausea and vomiting. And large heart attacks can lead to heart failure. Always auscultate. Are there any pulmonary ralls? And if it is a right side of the heart, right ventricular involvement, then right ventricular failure, that will lead to physical symptoms of distended neck veins. Similarly, when the heart fails, you will hear a third heart sound. If the heart is very stiff, then you will hear fourth heart sound. Any new murmurs, because MI can lead to infarction and that can lead to papillary muscle necrosis. That can lead to mitral regurgitation. So new murmurs, hypotension, shock, these are the things that you need to look for. Now, what are the points in favor of MI? Patients often have a history of angina or a previous chest pain, murmurs, arrhythmias, risk factors. Always you need to risk profile your patient with MI. A male, risk factor. Smoker, risk factor. Sedentary lifestyle, risk factor. Poor lipid profile, risk factor. Similarly, hypertension, diabetes. And always take the drug history. Digoxin, furosemide, cholesterol medications, antihypertensives. What is the patient taking? You need to look for. Now, how do you treat MI? You have to admit in the intensive coronary care unit. And what are the important principles? Early reperfusion. If the time from the onset of symptoms is less than 12 hours, it's a good time, golden time for early reperfusion. Very early reperfusion is fewer than 4 to 6 hours is the most preferred one to salvage the myocardium. If the ST segment elevation is clearly documented, you can do fibrinolysis or percutaneous coronary intervention like balloon angioplasty, or you can put a stent. And if there is a diffuse coronary vessel lesions, then coronary artery bypass grafting may be required, CABG. You need to do EKG monitoring, because what is the cause of death in acute MI? Patients will develop ventricular tachycardia and ventricular arrhythmias. So if there is a ventricular tachycardia, how will you recognize ventricular tachycardia? Always a tachycardia with a broad QRS complex is a ventricular tachycardia, and a narrow QRS complex is a supraventricular. So if there is ventricular tachycardia, you need to administer amitriptyline, is very important. You give oxygen by nasal cannula and you maintain oxygen saturation more than 90%. Control the pain with the morphine, which will improve the pulmonary edema if it is there. Aspirin, nitroglycerin, they are the standard prescription in case of MI. You need to consider beta blockers. Beta blockers, if there are no other specific contraindications, the patient should be advised to take them for life. What are the importance of beta blockers? Beta blockers are those medicines which are known in a lot of studies that they reduce the mortality in a patient who suffered MI. Similarly, the chance of getting another second heart attack is prevented by administration of beta blockers. You administer clopidogrel antiplatelet, unfractionated or low molecular weight heparin as an antithrombotic, and very important, ACE inhibitor, it need to be started within 24 hours. And you need to give HMG-CoA. Reductase inhibitor is a standard part of the prescription when the patient is discharged after an acute MI. So these are some of the common things, doctor, that you need to know about MI. Now let us get into action. What is action? Let us look into an actual case of myocardial infarction, and let's look his 2D echo. 2D echo. So this is a 54-year-old man. 54-year-old man who presented with chest pain, also elevated JVP, and let us look his 2D echo. So in this parasternal long axis view, aorta is normal, and there are no overt wall motion abnormalities you are able to see in the LV. LV is moving very well, and there is no regurgitation or stenosis. So there is a slight mitral regurgitation, but nothing particularly exciting. This is the M mode, and here you are able to see the septum and mitral valve. Through that you are able to look for the M mode, and the mitral valve movement is slightly abnormal, and there is nothing very much pinpointing here, and RV, the right ventricle, looks more or less normal. And now let us look into the RV. Here you can see the tricuspid anterior and posterior leaflets are moving very well, but the right ventricle appears slightly dilated and a little hypokinetic. You are able to see there is some amount of tricuspid regurgitation. Here you are seeing the relation between the right atrium and the right ventricle, where there is turbulent flow. And this is the short axis view. The RV looks little bigger than the LV. The right ventricle looks slightly bigger than the LV. And the interventricular septum appears to be slightly pushed. Now this is the apical 4-chamber view, and you can see that the left ventricle is pretty moving very well, and in this the RV is not showing any, the right ventricle is not showing any gross abnormality in its motion. That's what you're able to see. Now this is the typical apical 2-chamber view, and in this also there is nothing very dramatic, but there is a little thickening of the inferior wall, and now this is a focused apical view. This is the place where you have the clue, and you can see that the base of the right ventricle, is moving, is a kinetic. RV is definitely dilated in this 4-chamber view, is what you are able to see. And that is the place where you are having a very important clue. So the right ventricular infarct is what you are able to see. And this is the way that on 2D echo you can demonstrate objectively that there is an infarction and that is affecting which wall. You know very well that inferior wall MI, where the right ventricular affliction is very high, especially when the right coronary artery is occluded. You need to basically identify the wall motion abnormality in the right ventricle. So that's how 2D echo brings objectivity in the diagnosis of the myocardial infarction. I hope you all enjoyed this, and we will be having many more 5-minute videos with which we will be able to do the revision. So please be tuned and also be part of our Telegram group, and we will make the preparation very vibrant, working together. So today evening we have a gynecology discussion. Please be tuned. Infertility is the topic that we are going to discuss. This is Dr. Murali Bharadwaj signing out. Your everyday, every moment, 24/7 classmate, roommate, benchmate, studying along with you, inspiring you to become the toppers in all the NEET PG, FMGE, USMLE, and the MBBS exams. Bye-bye, ta-ta.